Thank you for joining me in today's video about rejections and denials. If you're a part of a private practice, then most likely you'll be dealing with rejections and denials. If you work in a hospital, you might not deal with it because that might not be your department, even though you're in billing, but it's still something good that you should know. So keep watching if you're interested. My name is Tamika, and I'm a certified professional biller. We're going to jump right into it because we don't want to make it too long. And if you know anything about rejections and denials, there are thousands of them. So, of course, I can't go through all of them in one video, but I'm just going to go through some of the top ones that I think is most frequent when it comes to a rejection and denial. When you have rejections and denials, you usually have a zero payment, meaning that nothing is paid on the claim and you might have to send it again, make corrections, and we'll go through all of that when we go through the different codes. A rejection is one that is usually, it doesn't even reach to the insurance company. If you send it electronically, the claim that is, if you send the claim electronically, which most of the time that is how we're sending it nowadays, even though we still send it by paper, most times claims are sent, they are sent electronically. So you usually send an electronic claim through your clearinghouse. You can get a clearinghouse rejection or you can get a payer rejection. And usually if you get either one of those, they don't have a claim number because they have not even passed the portion to get a claim number. When you have a denial, it usually goes through to the payer and it gets a claim number. So when it's sent back to you, when you make any corrections or anything like that, you need to reference the claim number that it has. So basically the difference between a rejection and a denial is most likely that if it's a rejection, it has not gone all the way through to the insurance company. And if it is a denial, that means the insurance company has it on file, has processed it, but it was denied. So I hope that was clear. Now, each of the denials have different codes to them. So when they go through to the insurance company, they come back with a rejection code or a denial code or a remittance advice code that is on the remittance advice, okay? So it lets you know why the claim was denied or not. There are three common codes, I guess I can say, which is PR, CO, and OA, which you would see before the numbers, okay? So it might say something like PR, which stands for patient responsibility, CO, which stands for contractual obligation, or OA, which stands for other adjustments, and then it would have a number to it. Also on the remittance advice, you will find that there are claim adjustment reason codes, which tell you why a claim or service line was paid differently than what it was billed. You would also find remittance advice remark codes, which provide additional explanation for the claim adjustment or information about remittance processing. And there are two types of remittance advice remark codes. There are supplemental and there are informational. Now, the ones that we'll be going over is a combination of them. So it's just depending on what the code remark means. The first one is duplicate claims, and the code for that is OA18, other adjustment 18. Now, when you have a duplicate, you need to find out if it is a true duplicate or not. If you get a claim back and it's denied because it says it's a duplicate, but you have not received payment for it, you need to find out why they're saying it's a duplicate. Do they have something else on file? You need to call up the insurance company and figure out, have you received another claim like this? Or it can actually be a true duplicate where you go in your system and you look to see if this date of service was already paid, but for some reason you sent out the claim again. Also, it can be that it was supposed to be a corrected claim, but the insurance put it as a duplicate claim because they didn't see any change or any difference in the claims. So you might have to, again, call up the insurance company and say, well, this is not a duplicate claim, it is a corrected claim. Then there's PR 33, which means the patient cannot be identified. Now, PR stands for patient responsibility, meaning that if the patient couldn't be identified, then it's going to be the responsibility of the patient to pay for the services. Sometimes that is a correct denial and the patient maybe have been terminated. Maybe they were on the insured's policy or the subscriber's policy, but they were terminated. So that can be a true denial, but you need to make sure that that is true. You can either call up the patient and find out if they are still on the insurance, or if they have another insurance, or is it just that the insurance company hasn't updated the information so they're not in the system, but they do belong on the policy. Now, before I continue on, I wanted to say that not all the insurance companies use these standard sets, okay? Most of them use them, but not all of them. So you might be working with a smaller insurance company and the reason is that the insured cannot be found, but they don't use PR 33. Sometimes it is different codes and you will have to figure out what that particular insurance company is saying because they don't use the same standard codes. Then there's CO 22, which is a contractual obligation for coordination of benefits. If you see CO, that means that you can't bill the patient. So you need to find out what it is and why they're denying it. Coordination of benefits mean that there is a primary insurance to the insurance that you're billing, and you need to add the explanation of benefits with your claim so they can see what the primary paid. Now, most of the time, most people have a primary and a secondary, but if they happen to have a tertiary insurance, then you need to also include the primary, the secondaries, EOB, and then the third one. Okay, so they need to see what the other insurance has paid, especially if they're not primary. So if they don't have that and they have on file that the patient has a primary insurance, they will not pay a secondary because they have not received the EOB from the primary. CO 97 is global services. This means that what you're trying to bill for is not going to be paid because it is included in a global package. So for instance, let's say you're in OBGYN and you're billing for a delivery, or not even a delivery, the complete maternity package. So you're billing for the complete maternity package and then you bill a service that is outside of that package. Let's say you bill for the patient had to have another procedure that was not related to her pregnancy done within the time that she was pregnant. You need to make sure you put a modifier on that because they will include everything that was done in that global package. Also, I don't want to go too deep either. It's something that I would probably have to explain in another video. But also when you have global packages, you have a certain amount of days that you can bill services for that particular procedure. So let's say if you had a surgery. If I had a surgery and I had it done today, October the 20th, and my surgery had a global period of 90 days, that would mean that you cannot bill anything for me, any visits that pertain to my surgery for me within those 90 days and get paid because they are included in my surgery. Anything that is not related to my surgery, you would have to append a modifier to it because that's the only way the insurance company is going to know that it's not included in my global package. CO 15 is no pre-authorization. So when you have surgeries done, you need to have them pre-authorized. And not only surgeries, there are other like CTs, MRIs, certain things that you need to have pre-authorized in order for the insurance to pay for the services. And if you do not have that pre-authorized, then they're not going to pay. And it's not going to be the responsibility of the patient, it's going to be the responsibility of the provider's office. That's why it's CO 15. And if you ever get a denial like that, you're going to want to see, number one, if you actually did get your services pre-authorized. If you did, you need to call them up, give them the pre-authorization number. If you didn't, you might have a harder time because they want you to pre-authorize before you actually do the services. And if you don't, you'll have a really hard time getting your services paid after the fact. Make sure you look at, most likely there's a list for different insurances when you're doing procedures that they have for you to look at, so they can say this needs to be pre-authorized, this needs to be pre-authorized. Not everything needs to be pre-authorized, but a lot of the surgeries do. So you want to make sure that you have that done before you do a surgery, because then you'll be doing it for free because they wouldn't pay you. PR27 and PR26 is the coverage was terminated and prior to coverage. So PR27 is the coverage was terminated, meaning at the date of the service that was done, the person no longer had insurance. And PR26 means that the date the service was done, the patient didn't have insurance yet. So it's kind of the same, but if I have a procedure done, a visit, I got into a doctor's office on 10/20, and you get back a PR27, they would tell you that that means my coverage was terminated before 10/20. But if you get back a P26, that would mean that my policy did not become effective until maybe 10/25, and I came in on 10/20. And if you get any of the PR, again, that would mean that it's the patient's responsibility. So if my policy was terminated or wasn't effective yet, it's going to be the responsibility of the patient. And also you can watch this video that I did, which explained about checking eligibility for patients, because you want to make sure that a patient is eligible for the services before you actually do them. You don't want to be doing services on patients and then you find out later on that they don't have coverage. Not that you can't bill them, but when you bill them, you might have a harder time in collecting the money, and you just want to make sure that they are covered and there's no surprises for them when it's time to make a payment. CO29 is timely filing. Now, we've all had those timely filing denials, and with those, it hurts your heart because for each insurance company, you have a specific amount of time that you have to bill the claim. Medicare, for example, is a year. So if the date of service is 10/20/2022, I have up until 10/20 of 2023 to bill the claim out. Of course, you don't want to wait that long, but sometimes things fall through the cracks and you miss a claim for whatever reason, and you might find out later on about timely filing. With timely filing, if it is a true timely filing denial, meaning you waited after the time, then there's nothing you can really do to get paid. But sometimes you have actually sent the claim, but the insurance says they didn't receive it or something to that effect. So you just make sure that you have proof that you actually sent the claim. If you're sending it electronically, that's a good way to have proof, because when you send it through your clearinghouse, they'll have like a date and time and transaction numbers that you can show to the insurance companies. But if you mail it and you don't mail it, let's say with return receipt or anything like that, which we mostly don't do that, it'll be harder to prove that you actually sent the claim before the timely filing limit was up. CO50 is not medically necessary. Now with this, that can mean that the diagnosis code that you put with the CPT code does not provide a medical necessity. Let's say you did an ultrasound of your leg, but your diagnosis is a earache. The insurance company would say that was not medically necessary. It's no reason for you to do the ultrasound for an earache. Of course, now that doesn't make sense and you should never do that. But let's say you did. That's something where the insurance would say it's not medically necessary. There's also something called local coverage determinations and national coverage determinations that will tell you what the insurance company feels are diagnoses that warrants certain procedures or certain services. So you need to make sure that if you get a denial of CO50, that you look through your local coverage determinations or your national coverage determinations and see if your diagnosis is on that list of being medically necessary to do that service or procedure. CO15 is missing information on the claim form. This one is one that you will probably send in a corrected claim after you get this denial. So you might be missing your CLIA number, you might be missing your referring doctor's number, you might be missing an NPI number, something to that effect you might be missing. And what they're basically saying is you're missing some pertinent information. We need this information, and in order for us to process the claim, you need to put this information on the claim. So in a situation like that, you would do a corrected claim because they actually processed the claim, but now they processed it, but they denied it. So you need to do a corrected claim with the original claim number on it to say, well, okay, this is the information that you needed. Again, it's a CO code, so the patient would not be responsible. This is the responsibility of the provider's office. And CO 231 is mutually exclusive procedures. When you get one of these denials, you want to check your NCCI edits to make sure they are in fact mutually exclusive. If you've used these edits before, you know there are some that you just can't add modifiers to, and there are some that you can add a modifier to make sure that they are unbundled, if you want to put it that way. So watch this 2-part video where I discuss common claim errors in medical billing, and I hope to see you next week.